Good afternoon, everyone. Welcome to Climb Bio's Investor Day presentation, during which members of Climb Bio's management team and an external expert will provide an update on the company's strategy and focus on developing therapeutics for immune-mediated diseases. Please note that various remarks that may be made on today's call about future expectations, plans, and prospects for Climb Bio constitute forward-looking statements for purposes of the safe harbor provisions under the Private Securities Litigation Reform Act of 1995. Actual results may differ materially from those contained in these forward-looking statements as a result of various important factors, including those discussed in the Risks Factors section of the company's most recent quarterly report on Form 10-Q, which is on file with the SEC. In addition, any forward-looking statements represent the company's views as of today and should not be relied upon as representing its views as of any subsequent date. While the company may elect to update these forward-looking statements at some point in the future, it specifically disclaims any obligation to do so, unless required by law. Any forward-looking statement should not be relied upon as representing the company's estimates or views as of any date subsequent to today. With that, I'd like to turn the presentation over to Aoife Brennan, Climb Bio's CEO.
Thank you, Chris, and thank you all for joining us today for our Investor Day event. My name is Aoife Brennan, and I'm the President and CEO of Climb Bio. It gives me great pleasure to introduce you to our newly rebranded company that has formed around the singular mission of developing better treatments for patients living with immune-mediated diseases. At Climb Bio, we believe that the 50 million Americans and many more people around the world living with immune-mediated diseases deserve better treatments. By focusing on their needs, we believe we can leverage new discoveries in molecular immunology and antibody engineering to deliver truly transformative treatments. A core component of our strategy involves developing deep relationships with the scientific community, listening to frontline physicians, and partnering with patients to ensure that we keep their needs front and center in everything that we do, so that the products we develop will be clinically impactful and commercially successful. Our new name, Climb Bio, pays homage to the journey each patient must travel and to the work we as a team are committed to doing to advance new treatments for some very challenging diseases. And what a team it is. In the 3 months since the acquisition of Tenet Medicines by the legacy Ellium organization that was the predecessor of Climb, we've been able to attract some world-class development talent, and you will be meeting many of the individuals on this slide today. Several members of the team have worked on budoprutug and similar assets at prior companies, and others have extensive backgrounds in biologics and immunology. So it's been wonderful to be off to a quick start as a team. We plan on continuing to thoughtfully build out the organization over the coming months and have recently signed a lease for a corporate headquarters in the Boston suburbs. We've also recently discontinued all operations in the UK and thank all of the legacy Ellium team members for supporting a smooth transition. Our lead asset, budoprutug, is an anti-CD19 monoclonal antibody. Budoprutug has been evaluated in an ascending dose study in oncology, where it was generally well tolerated at doses of up to 1,000 milligrams weekly over 4 weeks. It has also demonstrated compelling proof of concept in a phase 1b trial in patients with primary membranous nephropathy. You will hear more on those data later today. With mounting evidence of the role of B-cell depletion in many immune-based diseases, and of the importance of CD19 expressing B-cells in particular, budoprutug has the potential to address a wide range of diseases. To systematize our approach to developing budo, we've considered indications across 3 opportunity sets, namely IgG4-mediated diseases, diseases caused by IgG1 to 3 that impact a single organ system, and complex systemic diseases. As part of today's agenda, we will be taking you through each opportunity, reviewing the biological rationale for the role of CD19, and providing examples of some of the diseases that we believe can be addressed by Budo, including our lead indication for upcoming clinical trials. Our first speaker on the agenda today will be Dr. Stephen Thomas, who was a founder of Tenet Medicines and has been helping with the transition as interim CSO of Climb Bio. Stephen will be reviewing B-cell biology at a high level and outlining why we believe that CD19 is the preferred target for B-cell depletion in antibody-mediated diseases. He will also outline why we believe a monoclonal antibody is the modality with the broadest potential. Finally, Stephen will explain the key attributes of Budo and share some additional non-clinical data. Primary membranous nephropathy is a great example of an IgG4-mediated disease from our first opportunity set. We are honored to have Dr. Frank Kotizar, Director of the New York Nephrology, Vasculitis, and Glomerular Center, join us this afternoon. Dr. Kotizar is an expert in renal disease and has a special interest in membranous nephropathy. He was the lead investigator of the phase 1b study evaluating the safety and efficacy of Budo in patients with PMN and enrolled several patients. He also has experience administering Budo to a patient with minimal change disease, a different glomerulonephropathy under a separate protocol. He plans to share that case study with us today also. Complex systemic diseases remain stubbornly difficult to manage in clinical practice and continue to have a negative impact on quality of life, particularly for women. This is a disease area where a CD19 targeted antibody approach could potentially have a large impact, and there is nobody better to outline the science and opportunity than Dr. Jan Hilson. Jan has spent her entire career either caring for patients with systemic lupus and other immune-based diseases or successfully developing drugs to treat them. Jan will provide a brief primer on SLE, outline our plans for the phase 1b/2a study, and explain how data from that trial has potential to support expansion into other diseases in this opportunity set. We were recently fortunate enough to be able to attract Dr. Nishi Rampal to join the organization as SVP of Clinical Development, and Nishi will be taking you through our final opportunity set in single organ diseases, exemplified by our program in immune thrombocytopenia. A key attribute of diseases in this group is that they are frequently considered rare diseases, have validated endpoints for approval, and importantly, many have shown response, albeit suboptimal, to B-cell depletion with anti-CD20 targeted antibodies. Having successfully run development programs in several of these diseases in prior roles, Nishi will play a key role in guiding our development efforts and in identifying our next set of indications. Our final speaker this afternoon will be Dr. Brett Kaplan, COO of Climb Bio, who will be providing a corporate outlook and walking you through some upcoming milestones. Brett recently joined us and will play a critical role leading all corporate functions at Climb Bio. He has a background as an equity analyst, an investment banker, and a serial CFO, and will be an important partner to me as we build out the team. Brett's remarks will be followed by a Q&A session where I will be joined by members of the management team, and we look forward to fielding your questions. I will now hand over to Stephen, who will walk through the scientific background of our lead program in more detail.
Thanks, Aoife, for the introduction. I want to reiterate the excitement and enthusiasm at Climb Bio for the potential of our lead program, budoprutug. And furthermore, for the opportunity to build a pipeline focused on serving patients living with immune-mediated diseases. I've had the unique opportunity to work on or around this program for the past few years, and I firmly believe that no time is better than now to unlock and advance the potential utility of anti-CD19 monoclonal antibodies, and specifically budoprutug. Several lines of evidence are converging to support the hypothesis that CD19 expressing B cells are pathogenic culprits in B cell mediated diseases, and that CD19 targeted monoclonal antibodies may effectively, durably, and safely deplete this B cell repertoire to improve disease in patients. Over the next few slides, I will talk through the scientific background and rationale for our approach to targeting CD19 with a glycoengineered monoclonal antibody, and the key properties that instill our belief that budoprutug has the potential to be a patient-tailored, differentiated, and best-in-class approach with broad utility for the treatment of B-cell-mediated diseases. At the most basic level, one significant advantage that presents itself when targeting CD19 relative to other B-cell antigens is CD19's broad expression profile across many B-cell subtypes. This slide depicts the B-cell lineage from progenitor B cells to plasma cells and highlights where various B-cell antigens show expression. As conveyed by the yellow bar, CD19 antigen is found on early pro-B cells and maintains surface expression throughout maturation to short-lived plasma cells. While CD19 expression tends to wane on long-lived plasma cells, we view this as a potential feature, given those cells are a key component of humoral immune memory, for example, conferring long-term protection post-vaccination. Most importantly, the ability to target both autoantibody secreting cells and their progenitors provides a unique opportunity for rapid onset of action and durability of self-reactive B cell depletion, which could potentially maximize clinical benefit for patients with B cell driven diseases. Climb's lead program, budoprutug, is a highly potent anti-CD19 monoclonal antibody designed with enhanced effector function and potent antibody-dependent cellular cytotoxicity, or ADCC. There are several unique attributes of budoprutug that have the potential to differentiate our molecule from other treatments for autoantibody-driven diseases. Budoprutug's low picomolar affinity for CD19 has the potential to overcome lower antigen density of CD19 on some B cell subtypes, such as plasma cells, and enables direct targeting of those pathogenic B cells, which sit upstream as a source of inflammation. The glycoengineered, low fucosylated Fc region of budoprutug increases affinity for Fc gamma receptors, thereby functionally enhancing ADCC. We believe that enhanced effector function, coupled with potent antigen binding, will drive deep and durable B cell depletion. In clinical studies of budoprutug, subjects receiving as low as 100 milligram induction doses achieved undetectable levels of circulating B cells for at least 6 months, while repeated doses as high as 1,000 milligrams once weekly for 4 consecutive weeks were generally well tolerated. Additionally, we've been able to successfully formulate budoprutug to concentrations exceeding 175 milligrams per milliliter, while maintaining low viscosity, creating an opportunity to pursue a subcutaneous dose form that potentially features a low volume injection. We believe there's an opportunity to optimize both the dosing regimen and dose form for specific patient populations, potentially enabling a patient-tailored approach to disease management. These key features of budoprutug combine to create an exciting opportunity for broad utility across the many immune-mediated diseases making life difficult for patients today. We seek to position budoprutug as a best-in-class approach, capable of delivering on efficacy, safety, and convenience. In the evolving landscape of B-cell targeted therapies, we've seen a lot of excitement for CD19 targeted approaches across multiple construct classes, including monoclonal antibodies, cell therapies, and T-cell engagers. At Climb, we view a monoclonal antibody-based approach to targeting CD19 as ideal for 4 key reasons. The first is manufacturability, the right construct. Monoclonal antibodies traditionally have well-established manufacturing and supply chains, favorable cost of goods, and scalability. Given the millions of patients globally suffering from autoantibody-mediated diseases, the ability to readily scale manufacturing and drug supply may be critical to realizing the full potential of a product candidate like budoprutug. The second is efficacy, the right target. CD19 targeted therapies developed by third parties have demonstrated impressive efficacy in controlled trials and case reports of patients with autoimmune diseases, even in patients who have failed or relapsed on other B-cell targeted therapies like anti-CD20s. This is potentially driven by CD19's unique expression profile across the B-cell lineage and the ability to directly target plasmablasts and plasma cells. Importantly, B-cell depletion with an anti-CD19 can be considered upstream of other approaches to autoantibody-mediated diseases, like the FcRn-targeted therapies, which may have less impact on the source of pathogenic autoantibody production. The third is safety and tolerability, the right modality. Anti-CD19 antibodies developed by third parties have demonstrated a favorable safety and tolerability profile to date, comparable to anti-CD20s. Physicians have prescribed B-cell depleting therapies for decades with an ever-increasing safety database, improving the level of comfort in directly depleting an immune cell type, even via self-administration in an outpatient setting. The fourth is patient-tailored, the right dosing regimen. Targeting CD19 with a monoclonal antibody presents the opportunity for an optimized dosing regimen. A highly correlated and readily detectable pharmacodynamic marker of B cells potentially supports a treat-to-target approach that is tailored to a disease state and can be personalized to each patient. This could represent a highly differentiated approach relative to traditional biologics used to treat autoimmune diseases. Taken together, these characteristics potentially support a best-in-class product profile that could enable broad utilization across a large and diverse range of patient populations. One criticism we often hear of the monoclonal antibody-based approach to CD19 targeted B-cell depletion is that monoclonals are unable to reach tissues, the desired site of action, and even if they do, they lack the potency and functionality to deplete B cells within those tissues. While we currently lack patient-level data with anti-CD19 monoclonal antibodies that directly demonstrate B-cell depletion at the tissue level, there is a plethora of clinical evidence from the widespread use of anti-CD20 monoclonal antibodies, namely rituximab, showing that a monoclonal antibody can induce dose-dependent reductions of target antigen-expressing B cells in tissues. On the left-hand side of the slide are kidney biopsies from a transplant patient before and after rituximab treatment. The upper window within this panel shows diffuse staining of CD20 expressing B cells prior to treatment with rituximab. Post-treatment, we observe clearance of the same population. What's particularly striking about some of these case studies is while rituximab clearly depletes the CD20 positive B cell population resident within many different tissue types, including lymph node and spleen, a likely problematic and pathogenic B cell population remains, as it's not effectively cleared by a CD20 targeted approach. The middle and right panels show that in both lymph node and spleen, rituximab again clears CD20 positive B cell compartments. However, it leaves behind a CD19 or CD79A positive population that is presumably CD20 negative. This phenomenon speaks to what we view as a key advantage of CD19 targeted therapies, but also clearly demonstrates that monoclonal antibodies can penetrate tissues and effectively deplete antigen-expressing cells within those tissues. As mentioned earlier, a key attribute of budoprutug is enhanced ADCC, driven by potent Fc gamma receptor interactions with budoprutug's low fucosylated Fc region. On the left-hand side of the slide, we show that budoprutug's glycoengineering improved potency relative to a budoprutug construct containing a wild-type IgG1 backbone. The right-hand side of the slide shows that budoprutug demonstrated improved cell-killing potency against Dowdy lymphoma cells relative to rituximab, an anti-CD20 monoclonal antibody. We believe this feature of budoprutug will potentially lead to deep and durable depletion of both peripheral and tissue-resident B cells in patients with immune-mediated diseases, providing significant opportunity for clinical benefit. To further assess whether budoprutug specifically was capable of achieving B cell depletion in tissues, we developed a transgenic mouse model where mouse CD19 was replaced with human CD19 in a C57 Black 6 mouse. Budoprutug, like some other anti-CD19 monoclonal antibodies, is not cross-reactive with murine CD19, and this model provided the opportunity to evaluate B cell dynamics in vivo as a translational concept. For these experiments, human CD19 transgenic mice were treated once weekly for 4 weeks with budoprutug at doses ranging from 0.1 to 100 milligrams per kilogram. Tissue samples were taken 7 days post-dose and analyzed via flow cytometry for CD20 positive B cell counts in bone marrow, lymph node, and spleen. We observed dose-dependent B cell depletion in all tissues analyzed at day 28. Greater than 90% depletion was observed in all tissues analyzed at the highest dose tested, again reinforcing the notion that monoclonal antibodies penetrate tissues and can induce deep B cell depletion. We believe these data lend further support to the advantages of using a CD19 targeted monoclonal antibody to deplete autoantibody secreting cells in tissues, and that this concept is translatable to humans given other compelling evidence from earlier slides showing tissue level depletion with anti-CD20s in patients with autoimmune disease. One major advantage of our mechanism of action and indication space is the availability of informative serum biomarkers of disease activity that are translatable to clinical activity. We've developed 3 key aspects to our biomarker strategy that we believe can help accelerate proof of concept in patients, dose optimization, and ultimately benchmarking relative to other B cell depleting, namely CD19 targeted approaches. The first key aspect is autoantibody reduction. Our goal is to measure level, duration, and breadth of disease-related autoantibody reduction. Many autoantibody-mediated diseases have well-identified circulating autoantibodies that are readily detectable in serum. For example, later in this presentation, we will show you dramatic reductions in PLA2R autoantibodies in patients with primary membranous nephropathy treated with budoprutug. Importantly, reductions in autoantibodies are often predictive of clinical response. The second key aspect is peripheral B cell depletion and recovery. We can readily measure level, duration, and breadth of peripheral B cell depletion, which precedes reduction in disease-specific autoantibodies and provides a reliable, early, and robust PD marker. We know from historical experience with B cell depleting therapies that achieving and maintaining peripheral B cell counts at undetectable levels is critical to seeing clinical responses in patients. Within this category, we also want to consider time to peripheral B cell recovery with immunophenotyping. We strive to push the peripheral B cell PD marker even further by not only looking at time to B cell recovery, but also examining the phenotype of B cells as they repopulate. This context provides the opportunity to assess the potential for immune reset, where a pathogenic B cell phenotype is replaced by one that appears less primed to drive inflammatory response. One final key aspect is tissue B cell depletion. We strive to be able to assess level, duration, and breadth of tissue level B cell depletion when and where possible. In certain settings, namely academic centers and specialized clinical trial sites, it may be possible to obtain and characterize tissue biopsies pre and post exposure to budoprutug to further build upon a body of supporting clinical evidence for tissue level B cell depletion with monoclonal antibodies and/or CD19 targeted therapies. To round out this section of the presentation, I wanted to provide a real-world example of where we see the availability of a subcutaneous dose form leading to increased market uptake in the setting of B-cell depletion in an autoimmune condition. The graph on this slide displays quarterly sales of approved multiple sclerosis therapies over the last several years. As we can all appreciate, the anti-CD20 monoclonal antibody ocrelizumab has been a dominant product in this space. Ocrelizumab is administered as an IV infusion using an induction and maintenance regimen with dosing every 6 months. Several recent launches of MS drugs have failed to achieve appreciable market share relative to ocrelizumab. Interestingly, the only therapy to realize meaningful penetration is another anti-CD20 monoclonal antibody, ofatumumab. One key distinction between ofatumumab and ocrelizumab is dose form. Even though ofatumumab is dosed more frequently, the ability to administer ofatumumab as a subcutaneous injection may potentially be influencing patient and prescriber preference relative to ocrelizumab's IV infusion. We can envision a similar opportunity for budoprutug, where in indications that other anti-CD19 monoclonal antibodies may be establishing themselves as first-in-class, we may ultimately be able to deliver a differentiated offering. We've made excellent progress this year on our high concentration formulation. We can now formulate budoprutug in excess of 175 milligrams per milliliter and maintain viscosity below key thresholds for high injectability and syringeability. Our goal is to rapidly advance subcutaneous budoprutug toward an early understanding of safety, exposure, and pharmacodynamics relative to an IV infusion. To conclude this section on scientific background, I want to thank you all for your time and attention, and again reiterate the considerable opportunity before us with budoprutug in B-cell mediated diseases. We're excited by the key molecular features of budoprutug that potentially make it special, and the opportunity to develop budoprutug for the benefit of patients with autoantibody-mediated disease. With that, I'll turn it over to Dr. Frank Cortazar, Director of the New York Nephrology, Vasculitis, and Glomerular Center, who will dive into some of the exciting clinical data generated to date with budoprutug for indications in the IgG4-mediated disease opportunity set, including primary membranous nephropathy and minimal change disease. Dr. Cortazar will also touch on how we see this proof of concept as extensible to other diseases with high unmet need.
Thank you, Stephen. My name is Frank Cortazar. I'm a nephrologist with an interest in glomerular disease, and it's my pleasure to be with you today to talk about targeting CD19 in the treatment of autoantibody-mediated kidney disease. And for the most part of today, we're going to be using membranous nephropathy as a prototype for the type of disease for which targeting CD19 could expand therapeutic options. Membranous nephropathy, like most of the glomerular diseases, is a pathologic lesion, and it's so named based on the pathologic features seen on light microscopy. And you can see in this PAS stain here on the left on light microscopy that the basement membranes are thickened compared to a normal glomerulus. And the etiology of this is depicted on the right in the electron micrograph. You can see these immune complex deposits right here in the subepithelial space, right under the podocyte. And then you can see it right above that is diffuse foot process effacement, which is the pathologic correlate of the nephrotic syndrome. Membranous nephropathy is the most common cause of nephrotic syndrome in non-diabetic adults. In biopsy series around the world, it accounts for about 30% of biopsy cases, and the incidence is about 8 to 10 cases per million. We have conceptualized this entity into two different categories: primary membranous nephropathy, which is a renal limited condition without clear cause or insult that's leading to the development of the disease, and secondary membranous nephropathy, where there is a clear disease or medication or other insult that is leading to the manifestations. In primary membranous nephropathy, which accounts for about 80% of cases of membranous, it was identified in 2009 that the phospholipase A2 receptor is the target antigen in approximately 70 to 80% of cases. And since that time, there have been some other target antigens that have been discovered. The most well-defined is THSD7A, which accounts for about 2 to 5%. And in terms of secondary membranous nephropathy, there are a variety of causes: autoimmune disease, lupus being the most common. Class 5 lupus has a membranous pattern. Infections, particularly hepatitis B, drugs such as NSAIDs, and then particularly in older patients, malignancy can be associated with membranous nephropathy. Before the discovery of PLA2R as the target antigen in most cases of membranous nephropathy, it was unclear the mechanism by which the immune complexes were depositing in the subepithelial space. And there were three possibilities. One is that the autoantibody is meeting its target antigen in circulation, and then the immune complex is depositing in the subepithelial space. Option 2 is that an autoantibody was generated against an endogenous podocyte antigen. And then option 3 is that the antigen was coming from the circulation, depositing in the subepithelial space, and then the autoantibody was forming an in situ complex right there at that level. And with PLA2R, it became clear that in primary membranous nephropathy, what's occurring is depicted in panel B. There is an autoantibody against an endogenous podocyte antigen. Again, in most cases, it's the PLA2R antigen. And this is leading to podocyte damage and proteinuria. What's depicted in panel A and C is what we think is occurring in cases of secondary membranous nephropathy. For example, you have antibodies against double-stranded DNA and DNA in lupus that are then depositing right underneath the podocyte. And conversely, you can imagine hepatitis B surface antigen, for example, complexing with the antibody in situ underneath the podocyte. But again, in most cases of primary membranous nephropathy, it's an autoantibody against the phospholipase A2 receptor, and this is depicted here. And once the phospholipase A2 receptor is engaged by the autoantibody, complement is activated. The membrane attack complex C5b through 9 then causes podocyte damage, and that leads to proteinuria. And depicted over here in this immunofluorescence micrograph is what we do clinically to diagnose this condition. On the upper panel, it's looking for IgG deposited, and you can see this granular deposition along the glomerular basement membrane. And then in panel D, which is staining for the PLA2R antigen. And this is done now in every case of membranous nephropathy to define whether it's PLA2R positive or negative. And the reason it stains is because as the antibody targets the target antigen, PLA2R becomes overexpressed at the level of the podocyte, leading to this staining pattern. And then in addition to the staining at the level of the biopsy, we can also test for antibodies to the phospholipase A2 receptor serologically. In terms of presentation, the majority of patients, approximately 2/3, are nephrotic. They present generally with edema, and having the nephrotic syndrome itself leads to a number of complications. The edema can be debilitating. There are patients who have difficulty ambulating. Some patients develop ascites and pleural effusions. Hyperlipidemia is one of the manifestations of the nephrotic syndrome, which can cause accelerated cardiovascular risk. All forms of the nephrotic syndrome are associated with the development of thrombosis. The hypothesis is that there's a mismatch between procoagulant and anticoagulant factors, and in particular, the loss of antithrombin 3 seems to be important. But interestingly, membranous in general has the highest risk of thrombotic events, with approximately 10% of patients having a thrombotic event around the time of diagnosis. And infection is increased because in the nephrotic syndrome, often patients are losing immunoglobulins at the level of the glomerulus, and the hypogammaglobulinemia precipitates an infectious risk. So once a patient is diagnosed with membranous nephropathy, they are risk stratified in terms of their risk of progression. This algorithm is largely adopted from the 2021 KDIGO guidelines. And you can see here on the left that the patient is at low risk, they're not nephrotic. Often we will put them on conservative therapy with an inhibitor of the renin-angiotensin system. And if they do not progress, we will just monitor the patient because their overall natural history has a good prognosis. However, if the patient is nephrotic and remains nephrotic after conservative therapy, then immunosuppression is generally indicated. For the lower risk patients who remain nephrotic, the recommended therapy is rituximab or a calcineurin inhibitor. As the proteinuria increases, particularly to above 8 grams per day, then the risk of decline increases. And so the recommendation is for more intensive therapy, again, rituximab, or we see cyclophosphamide introduced here as an option. And then for the highest risk patients, these are patients with decompensated nephrotic syndrome or patients who are having rapid declines in kidney function. The recommendation is to use cyclophosphamide in combination with steroids based on some observational data that cyclophosphamide is better in this population. This slide highlights the importance of attaining a remission in nephrotic patients. This is a report of 348 nephrotic patients from the Toronto Glomerulonephritis Registry. And what you can see is their outcome separates very nicely in terms of their remission status. So patients who achieved a complete remission essentially had no risk of ever progressing to end-stage renal disease. Patients who had a partial remission did certainly better than patients who achieved no remission, but some of them still progressed to ESRD over time. And then if you look at patients who achieved no remission, they have very poor outcomes, such that by 10 years, more than half of them had progressed to end-stage renal disease. So what we're really aiming for clinically, if possible, is to achieve a complete remission, which is generally defined as a proteinuria of less than 0.3 grams per day. Before we look at treatment regimens and outcomes, it is important to note that in cases that are PLA2R antibody positive, the antibody titer during treatment can be used as an early marker of therapeutic efficacy. In the table here on the left, we're looking at 81 nephrotic patients with PLA2R-associated membranous nephropathy who were treated with rituximab. And what we can see is their remission status separates out very nicely by the decline in the PLA2R antibody titer observed. So patients with only a moderate decline had no remission, whereas patients who had complete immunologic remission had a very high rate of achieving a complete clinical remission in terms of proteinuria. And with the table on the graph on the right shows is that the proteinuria lags far behind the change in PLA2R antibody titer. So if you look at the patients who achieved complete remission, they had a very rapid decline in the PLA2R antibody titer, such that it was in the normal range close to about 3 months, but the proteinuria nadir was not reached for about 2 years. And this is important to realize that immune complex disease, such as membranous, resolves very slowly, and that's why using the antibody titers is useful to predict an early response. Okay, let's now turn to what we would consider standard of care treatment for membranous nephropathy. If you recall from that slide outlining the KDIGO guidelines, rituximab is recommended for the majority of patients. And this data is from the MENTOR trial, in which 130 patients with primary membranous nephropathy and a proteinuria of at least 5 grams per day were randomized to rituximab or cyclosporin. And you can see the remission rates here on the left. At 12 months, approximately 60% of the patients who received rituximab were in remission, compared with 52 who were receiving cyclosporin. And this is any remission, including complete or partial. Complete remission, again, is less than 0.3 grams per day. Partial remission is generally defined as a proteinuria of less than 3.5 grams per day and a 50% reduction from baseline. So this is any remission, 60%. And then again, at 24 months, the remission rate in the rituximab arm remained at 60%, but at 2 years, the remission rate in the cyclosporin arm was only 20%. And that's because the cyclosporin taper began at about 12 months. And with cyclosporin in particular, the relapse rate is incredibly high on discontinuation of the medication. And for that reason, I think most experts in this area are not using calcineurin inhibitors routinely in this condition anymore. But suffice to say, even with the recommended therapy for most patients, only 60% of patients are achieving any remission. And of course, that leaves 40% of patients receiving rituximab with no remission at all. And if you recall from the outcome slide, what we really want to achieve is a complete remission. And if you look at complete remission with rituximab, by 12 months, it's a little bit less than 15%. And then even when you carry it out to 24 months, less than 40% of patients, only about 35%, are achieving a complete remission. And then in terms of immunological remission, which they defined as a PLA2R antibody titer of less than 40, which is still positive. 14 is the upper limit on the assay. You can see again, only about 2/3 of patients receiving rituximab are achieving an immunological remission. So while it is effective in some patients, there is a large population of patients for whom rituximab is not effective. What about cyclophosphamide? If you recall in the KDIGO guidelines, cyclophosphamide is recommended for the highest risk patients, namely those with decompensated nephrotic syndrome and rapidly deteriorating kidney function. And the reason for this is there's been evidence that it works more rapidly than rituximab, and that's important in patients who are critically ill. So this study, the ReCycle trial, looked at 74 patients with primary membranous nephropathy and randomized them to rituximab or a Ponticelli regimen, which is cyclophosphamide alternating with steroids. And you can see at 12 months, the complete remission rate in the cyclophosphamide arm was 32%, compared with 16% in the rituximab arm. So indeed, it does work more quickly. However, by 2 years, the remission rate was similar in both groups. So it's working faster, but in the end, it seems like the outcomes may be relatively similar. Again, in this higher risk patient, it is important to achieve a more rapid remission. But there are concerns about the toxicity of cyclophosphamide that limit its use. It's associated with cytopenias and requires weekly monitoring of the CBC, so it's very labor intensive in terms of monitoring. And there are risks associated with secondary malignancy and also infertility. So I will tell you, from a practical point of view, most nephrologists have shied away from using cyclophosphamide altogether. Why is rituximab ineffective for this large portion of patients with membranous nephropathy? I think when we think about the pathophysiology of what's going on, it provides some insight. So this disease starts with an autoreactive B cell, like most autoimmune diseases that are antibody-driven. And a portion of these autoreactive B cells differentiate into plasmablasts, which are short-lived, but do secrete autoantibodies. And then a small proportion of these subsequently differentiate into plasma cell compartments where they're in long-lived survival niches. There is a good evidence that in membranous nephropathy, a majority of the autoantibody secretion is coming from the plasmablast compartment. Importantly, when an autoreactive B cell differentiates into a plasma cell, it loses CD20. So when we're using rituximab to treat this disease, we're targeting the precursor of the autoantibody cell, but not the autoantibody secreting cell itself. And that leads to a delayed response because you're essentially waiting for the plasmablast compartment to die out, and then it can no longer be replenished if the patient's B cell depleted. But in the interest of achieving a more rapid remission, we have developed combination regimens using rituximab and cyclophosphamide, with the rationale that we can get the benefit from rituximab, but use some cyclophosphamide to treat this compartment, the plasmablast compartment, so that the effective onset is not so delayed and the patient doesn't remain nephrotic. So this is a regimen that we developed using rituximab, an 8-week course of cyclophosphamide, which is a lower exposure than you would use in a typical Ponticelli regimen, and a steroid taper. And these are the outcomes for 60 nephrotic patients that we treated with this regimen. And you can see they had very high rates of remission, about 100% partial remission and north of 80% in terms of complete remission, and all patients had an immunological response. However, I will tell you that this regimen requires close monitoring, and I do not think it's adaptable outside of specialized centers. And that's where targeting CD19 can be of particular value, because I think it's reasonable to think that with targeting CD19, you can get the same outcomes as we're achieving with this combination regimen, trying to target both B cells and plasmablasts. While CD20 expression is reduced as a B cell goes to a plasmablast, it turns out that plasmablasts retain CD19 expression. So by using an anti-CD19 monoclonal, you can target both the pre-B cells and the plasmablasts as well, which should lead to a rapid decline in PLA2R antibodies and subsequently clinical remission. And that was the rationale for using budoprutug in membranous nephropathy. And I'm going to take you through a phase 1b study that was completed. So patients were enrolled if they had a history of nephrotic syndrome and had greater than 2 grams of proteinuria on a UPCR. Patients received 2 induction doses at baseline and then 2 more maintenance doses at 6 months. And it was a dose escalation study. The first 4 patients received 100 milligrams every 2 weeks. And then subsequently, the next 4 patients received the 200 milligram dose. 8 patients were enrolled, but only 5 patients received all 4 doses. 1 patient dropped out after a single dose. It was not related to drug toxicity. And likewise, 2 patients dropped out after 2 doses. 1 was lost to follow-up and 1 opted to discontinue the study. No patients discontinued because of an adverse event. And since, as we already alluded to, time is needed to see response for this disease, we're going to focus on the 5 patients who received all 4 drug doses. In terms of the baseline characteristics, we had a UPCR of 4 grams, and in the 3 patients who had PLA2R associated membranous, the mean titer was 71. Here we're going to review the results of budoprutug study in membranous nephropathy. You can see on the graph on the left, the drug very effectively depleted B cells. In the graph in the middle, it's looking at the PLA2R antibody titers in the 3 patients who had PLA2R associated membranous nephropathy. And very impressively, you can see these rapid reductions in antibody level into the normal range. And if you recall from the mentor trial in patients receiving rituximab, only approximately 2/3 of patients achieved a immunologic remission with a higher cutoff of 40. Here, all patients achieved a level of less than 14. And then in terms of proteinuric response, again, we're seeing these very rapid reductions in proteinuria, much more rapid than has been observed with rituximab. All patients in this study achieved a partial remission, and 3 out of the 5 patients received a complete remission at a very early time point. If you recall that slide I showed you previously, after rituximab, the nadir proteinuria often isn't reached for 18 to 24 months. Here, within a year, 3 of the patients had achieved a complete remission, indicating a very rapid onset of action of this drug. The 2 patients that did not achieve a complete remission did achieve a complete immunologic response. And again, this is predictive of ultimately achieving complete remission if the patients are followed over time. And then importantly, one of the patients, patient 1, is one of my patients, and I received permission from him to communicate his subsequent outcome after the study concluded. He's 2 years after the last infusion and remains in complete remission with a negative PLA2R antibody. So it's possible that targeting CD19, in addition to leading to more rapid resolution of proteinuria, may also induce a more durable response. In terms of safety, the drug was well tolerated to the 200 milligram dose. There were no deaths. There were 3 serious adverse events, none of which were thought to be related to study drug. No patients discontinued due to an adverse event. 4 patients reported infections, 3 of which were COVID-19, and 1 was pneumonia. So in summary, budoprutug in membranous nephropathy was well tolerated and demonstrated clinical and immunological remission rates superior to rituximab based on the historical data that we have. We're going to change gears here and talk about another glomerular disease, minimal change disease. And like membranous, it's based on the appearance on light microscopy. And you can see that this glomerulus here looks completely normal, hence the term minimal change. However, on electron microscopy, what you can see is diffuse foot process effacement, again, the pathologic correlate of nephrotic syndrome. In terms of presentation, minimal change disease often presents with the sudden onset of nephrotic syndrome. It's a little different than membranous nephropathy, which is typically more insidious. In terms of incidence, it occurs in approximately 1 out of every 150,000 persons in the population. Uncontrolled, this disease leads invariably to complications of the nephrotic syndrome, including thrombosis and decompensated edema. The current standard of care is glucocorticoids used to induce remission. The complicating factor is that particularly in adults, a lot of patients have what's called frequently relapsing or steroid-dependent disease. These are patients who initially respond to high doses of steroids, but in steroid-dependent disease, as the steroids are being tapered, they have a relapse of nephrotic syndrome. And then in frequently relapsing disease, you're able to complete the steroid taper with the patient remaining in remission, but shortly after they relapse, such that the patient is having 4 or more relapses per year. And the clinical conundrum in these patients is that steroids are very toxic, but every time that steroids are tapered off, they relapse. And so alternative agents are needed. And historically, the drugs of choice have been calcineurin inhibitors or cyclophosphamide. In terms of calcineurin inhibitors, they can demonstrate efficacy, but like in membranous nephropathy, the relapse rate is extremely high with tapering of the dose. And with maintenance therapy with cyclosporin or tacrolimus, there's a high rate of nephrotoxicity. So this becomes kind of a catch-22 situation where the drug cannot be discontinued, but continuing it leads to nephrotoxicity. Cyclophosphamide can be effective, but again, there's this high toxicity in terms of cytopenia, secondary malignancy, and fertility issues. Interestingly, rituximab has emerged as an effective therapy for frequently relapsing or steroid-dependent disease. And I say interesting because until recently, the pathogenesis of this disease has been somewhat mysterious. It's been attributed to a circulating factor that is toxic to the podocytes, but there hasn't been an identifiable antibody. And so the mechanism by which rituximab was inducing remission was unclear. However, from a number of studies, it's clear that it is effective. This is a meta-analysis that was done looking at patients with minimal change disease who had steroid-dependent or frequently relapsing disease and were treated with rituximab. This was from our center up here, and it included a number of other reports. And you can see that, close to 90% of patients were able to maintain remission after receiving rituximab. However, these patients do relapse when B cells reconstitute. In the follow-up of these various studies, which averaged between 18 to 24 months, you can see that about a third of patients are having a relapse of the nephrotic syndrome as the rituximab wears off. As we previously alluded to, the mechanism by which rituximab was working in these patients is unclear, but recent data suggests that in at least a percentage of cases of minimal change disease, antibodies against nephrin, a protein in the slit diaphragm, is responsible for the disease. And in this report, approximately 40% of patients with minimal change disease, and even in patients with active disease who had not received immunosuppression, closer to 80% had autoantibodies against nephrin. And on the right are two patients with anti-nephrin antibodies who received rituximab, and you can see that the anti-nephrin antibody decreased with concomitant clinical remission. So this story is still evolving, and it's unclear if these antibodies are pathogenic or if it's an epiphenomenon. But I think there is mounting evidence that this mechanism is responsible, at least in a proportion of patients. So with that in mind, there was a study of budoprutug for complicated minimal change disease. Only one patient was enrolled before the sponsor decided to terminate the study, but the patient was from my clinic. It was a 57-year-old woman with a history of frequently relapsing minimal change disease. She had relapsed on tacrolimus when I met her. Thereafter, we prescribed a course of steroids. She achieved remission, but then relapsed within 2 months, and steroids were reinitiated, and then she was enrolled in this study. Similar to the regimen used for the membranous nephropathy study, she received 2 induction doses and 2 maintenance doses. Her B cells were effectively depleted, steroids were discontinued, and the patient remains in remission 18 months after the last infusion. Importantly, there were no safety signals. So this is another disease space where targeting CD19 can be effective, and based on the evolving understanding of pathogenesis, may provide outcomes superior to that seen with rituximab. So I will conclude there, and I will pass it on to Jan Hilson.
Thank you, Frank. I'm so glad to be here with you today. I'm a rheumatologist and clinical immunologist and have 2 decades experience in development of novel therapeutics for autoimmune disease. In contrast to membranous nephropathy, there are autoimmune conditions that are very complex in that there are several organ systems that are at risk and multiple mechanisms by which both B cells and autoantibodies can cause injury. Systemic lupus typifies this kind of complexity. Lupus comprises a heterogeneous group of disorders, all of which are characterized by the generation and persistence of autoreactive subsets of lymphocytes and antibodies. Diagnosis is based on the presence of autoantibodies that bind to nuclear antigen, along with clinical features, the most common of which are fairly nonspecific. These include rash, musculoskeletal pain, fatigue, cognitive impairment. Approximately 80,000 of the 240,000 patients with lupus in the US will experience very serious attacks on the kidneys, or less commonly, serious injury to blood vessels, the nervous system, circulating blood cells or platelets, liver, lung, or very tragically, loss of the fetus. The numbers and kinds of autoantibodies that arise in lupus go well beyond those that we routinely measure. Their targets and the mechanisms by which they cause injury vary, and this accounts for the differences in clinical presentations that we see in our patients. Some autoantibodies bind directly to cells that are then destroyed through phagocytosis or cytotoxicity. This is the case with thrombocytopenia and anemia in lupus. Some of the autoantibodies form immune complexes that deposit in blood vessels, causing inflammation that injures the adjacent tissue. This is the case with nephritis, synovitis, rash, and vasculitis. And there are some antibodies that bind mediators or cell receptors and very directly interfere with important functions. These include antiphospholipid antibodies that trigger the clotting system and cause strokes or miscarriages. And there are also antibodies to elements in the nervous system that are thought to be behind cognitive impairment, depression, and even psychosis that can arise in our patients. Treatment usually begins with corticosteroids to rapidly reduce inflammation, and then hydroxychloroquine or other antimalarials to reduce the risk of the next flare. When this isn't adequate, or when patients cannot reduce their steroids to a reasonable level, we bring in broad-spectrum oral immune suppressants, such as azathioprine or mycophenolate. Targeted inhibitors of interferon and of B-cell activating factors have recently received marketing authorization and are helpful in some settings. But despite best standards of care, up to 20% of renal patients still progress to end-stage renal failure. And the mortality from complications of treatment is high, especially cardiovascular mortality. And some patients simply don't respond. There is a need for therapeutic regimens that can reduce the use of steroids, address antiphospholipid antibody syndrome, and also address the fatigue and cognitive impairment and fetal risk. We need to be able to also prevent the accumulation of damage that occurs with repeated flares. B-cell depletion has shown promise for addressing these unmet medical needs. Although the addition of rituximab didn't show a significant difference compared to corticosteroids and immunosuppressants alone in either the LUNAR trial in nephritis or in the EXPLORER trial in non-renal lupus, in practice, rituximab has clearly made a difference for thousands of patients. Obinutuzumab, which is a second-generation anti-CD20 agent, rescued patients who lost response to rituximab in an open-label study. In a phase 2 study, addition of obinutuzumab achieved complete renal response in 41% of 63 patients by 2 years, compared to just 23% on corticosteroids and mycophenolate alone. And a phase 3 study is reported to have met its primary endpoints. 41% leaves a lot of room for improvement. There are several factors that are thought to contribute to the failure of depletion through CD20. These include incomplete B-cell depletion. And as Stephen points out, it also includes persistence of production of autoantibodies by non-targeted plasma cells and other pathogenic effects that can be mediated through CD19 positive B cells. Recent case reports of depletion through CD19 are encouraging. Specifically, CD19 CAR T cells achieved complete response in 8 lupus patients who were refractory to multiple prior lines of therapy. Deep depletion of B cells and autoantibodies was achieved, and importantly, cells that recovered following depletion had a more benign appearance, suggesting the possibility of a reset. But there are many practical challenges to generating CAR T cells, particularly in patients as sick as those with lupus. And there are safety challenges that may limit their use in all diseases outside of oncology. The question has to arise whether these kinds of results might be approachable with monoclonal antibodies alone without the T cell attached. To test this hypothesis, Climb Bio plans to conduct an open-label trial of budoprutug in patients with active lupus, pending clearance of an investigational new drug application. In addition to clinical response, the study is designed to evaluate the impact of 3 dose regimens on the speed and depth of depletion of circulating B cells, to look at the decline in the production of pathogenic autoantibodies, and to assess the nature of B cells and antibodies that are produced upon recovery. Utility in lupus will provide hope for other diseases. There are several other complex systemic diseases for which B-cell depletion has shown benefit, or at least is rational. These may include overlap syndromes, systemic sclerosis, myositis, antibody-associated vasculitides, and even subsets of rheumatoid arthritis and Sjogren's syndrome. In addition, though, there are many diseases with very well-characterized antibodies that damage single systems, for which depletion through CD19 may be of value. Nishi Rampal will present our approach to these disorders with special attention to our planned study in patients with refractory thrombocytopenia. Thank you so much.
Thank you, Jan, for walking us through the opportunity in complex systemic disease, more specifically, our approach to SLE development. I'd like to turn to our vision for taking budoprutug into diseases driven by IgG 1 through 3 that impact primarily a single organ system. I'm Nishi Rampal, the SVP of Clinical Development at Climb Bio, and as discussed, CD19 B-cell depletion has the potential to reshape the treatment landscape in immune-mediated disease. And with our unique treat-to-target approach, we aim to reach the patient throughout their treatment journey and meet their individual needs. While there are a number of diseases driven by CD19 positive B cells, and more specifically IgG 1 through 3, that we could pursue with budoprutug, our lead indication in this space is immune thrombocytopenia, or ITP. ITP is predominantly an IgG1 immune-mediated disorder with antiplatelet antibodies. These autoantibodies attach themselves to the platelet surface, marking the cells for the immune system, targeting both their production and circulation. This results in shorter platelet lifespan, with splenic destruction as a hallmark feature. The bone marrow attempts to compensate by increasing cell production, but the cascading immune disorder leaves patients vulnerable to the effects of thrombocytopenia. For patients, this low platelet count results in bruising or petechia and purpura, hemorrhagic episodes or extensive bleeding, and chronic fatigue. Children fare better than adults with the natural history of the disease taking a more benign course. Conversely, adults rarely have spontaneous remission. They're reliant on a number of treatments which contribute to higher mortality than is observed in age-matched controls. In the US alone, approximately 65,000 adults live with chronic ITP, and they face a complex treatment journey. In fact, the majority of these patients relapse after receiving first-line therapy, with subsequent lines of therapy only partially addressing patient needs. Looking at current treatment recommendations of the American Society of Hematology, we can clearly see the plight of many ITP patients and the significant unmet need. Even if a patient is fortunate enough to stabilize on first-line therapy, upwards of 80% relapse and move to second-line treatments, namely rituximab or thrombopoietin receptor agonists. Many of those necessitate third-line treatment with additional doses of rituximab and thrombopoietin receptor agonists, or a trial of fostamatinib or other ISTs. If unsuccessful, combination therapy and even splenectomy are considered. A more detailed examination of the current treatments and their mechanism of action reveals modalities that attempt to intervene downstream in disease pathogenesis. Anti-RHDIG, a first-line therapy, and fostamatinib, a third-line therapy, attempt to evade the already cascading immune-mediated platelet destruction. Other treatments, like thrombopoietin receptor agonists, try to boost bone marrow production of platelets. Few current treatments target upstream disease pathogenesis, with rituximab attempting to target pathological B cells, but falling short. Certainly rituximab or CD20 B-cell depleters are effective, but they can only address a limited B-cell lineage. Most importantly, plasma cells and plasmablasts, the autoantibody producing cells implicated in ITP, are not addressed by rituximab or CD20 depleters, a key feature that Stephen already highlighted. This fundamental shortfall may be overcome by budoprutug, a CD19 B-cell depleter that targets plasma cells and plasmablasts in addition to other cells across the B cell lineage. Rituximab depletes peripheral B cells, but its limited effect leaves tissues vulnerable and the underlying disease only partially treated. This slide has two figures that explain how ITP patients may fail rituximab due to the presence of CD19 positive, CD20 negative B cells, as evidenced by primary failures and, more commonly, high relapse rates. The figure on the right shows how CD20 negative B cells continue to drive disease through expansion and formation of germinal centers. Now let's focus on the bar graph on the left. Here we see the impact on splenic plasma cells. Recall that the splenic destruction drives disease. And in fact, splenic removal can be a last-ditch effort to regain disease control. In the pre-rituximab treated patient, only 2.4% plasma cells are found in the spleen, which is in dramatic contrast to the post-rituximab treated patient with nearly 75% plasma cells in the spleen. These pathogenic plasma cells, which are CD20 negative and CD19 positive, continue to wreak havoc with persistent immune-mediated destruction, likely from tissue-level expansion. Budoprutug, which targets plasma cells, as well as a number of cells across the B cell lineage, can potentially address this gap in the current treatment paradigm, not only serving as a more complete B cell depleter, but addressing the rituximab failure population. Additionally, our planned ITP trial considers individual patient needs, with a treat-to-target study design allowing for a personalized medicine approach. Let's take a look at how we plan to achieve this aim. Our planned ITP phase 2 trial, pending submission and clearance of an IND to the FDA for this indication, is a single-arm, open-label study in adult patients with chronic disease evaluating the safety and efficacy of budoprutug. It leverages learning from prior ITP phase 2 trials, where placebo rates have been historically very low. The primary endpoint will measure platelet improvement along with other disease parameters. However, truly unique to this study design is a treat-to-target approach that allows redosing based on individual patient needs. Patients will receive a treatment cycle at day 1 and day 15 for those who meet eligibility criteria. Investigators can then elect for a second cycle of treatment if improvement wanes, guided by individual patient laboratory findings and clinical needs. These parameters include low or falling platelet counts that are deemed clinically significant, coupled with B cell counts. ITP offers an ideal serological marker and platelet count that reflects clinical picture. Additionally, since B cells return at a variable rate in each patient, these two parameters taken together should allow clinical providers to create the just right treatment regimen to meet patients where they are. Ultimately, our goal is to pursue a personalized approach that aims to optimize treatment efficacy. Individualized medicine for the individual living with a rare disease. Looking beyond ITP, there are a number of diseases driven by IgG1 through 3 that impact a single organ system. The opportunity set I'm sharing on this slide shows possible future indications that may be well suited for budoprutug. In fact, CD20 B cell depletion has shown some efficacy in these diseases, but for reasons similar to ITP, patients have incomplete responses or frequent relapse. We believe that budoprutug has the potential to address many of these diseases by leveraging CD19 B cell depletion, treat-to-target approaches, and offering the potential of personalized medicine. I've appreciated the opportunity to speak today about our vision at Climb, and Brett will now share our corporate outlook and upcoming milestones.
Thank you, Nishi. Great to be back in front of you all, this time as COO of Climb Bio. It is an exciting time to be an immune-mediated disease company, especially in the CD19 space. We were particularly encouraged by the Uplizna myasthenia gravis data, which in our minds solidify anti-CD19's benefit over the anti-CD20s. We believe these data provide read-through for the mechanism supporting our indication selection strategy. We await the full data set, but given the robust top-line data and benefit in the primary and secondary endpoints, our conviction on budoprutug is further enhanced. As you have heard from this stellar team, budoprutug, our CD19 antibody, is a tremendous asset with best-in-class potential. I want to go back and reorientate the audience to our indication selection framework of IgG4-mediated, complex systemic, and primarily single-organ IgG 1 through 3 categories. This framework captures several dimensions, including market opportunity, time to market, and risk. As you can see, we have adopted a balanced portfolio approach with our first 3 indications, each representing a large market opportunity where we believe budoprutug is well positioned to succeed. In addition, as highlighted by the slide, there are several very attractive indications in each group that we are thinking through for a potential next wave. While budoprutug alone portends significant value creation, from a strategic perspective, it also provides a phenomenal cornerstone for us to bring in complementary assets and leverage our internal capabilities. Before I detail what we can look forward to over the next 15 months, it is worth pointing out what has been achieved since the closing of the Tenet acquisition in June 2024. As you can see, this is a team focused on execution. From a strategic perspective, with today's investor event, we have completed the pivot away from neurology. We are now a clinical stage company focused on immune-mediated diseases. We closed a $120 million PIPE in June, and as of September 30th, had $218 million on our balance sheet, funding the company through 2027. We made key hires complementing the existing team members, providing expertise and critical capability, enabling us to continue to execute and take Climb forward. We have engaged in a strategic alliance with a global CRO to execute our planned clinical trials, allowing us to maintain lean internal operations while leveraging the global reach of an experienced immunology operations team. Last, as Stephen mentioned, we have finalized the high concentration formulation to support our potential subcutaneous formulation. And that's all in the last 4 months. So what have we got to look forward to through 2025? We will complete our move into our Wellesley, Massachusetts headquarters and look forward to hosting you in our new offices before the end of the year. To remind you, we have also completely wound down our UK operations, simplifying our geographic and operations complexity. Subject to regulatory clearance, we can look forward to dosing our first patients in SLE and ITP in the first half of 2025 and advancing into late-stage clinical development in MN. We also will advance our subcutaneous clinical formulation, which provides optionality for budoprutug. And finally, as Aoife and I alluded to, there's always the possibility of opportunistic BD, which is an important part of our strategy. So before we move to Q&A, allow me to provide a wrap-up. We have completed the transition from a CNS company and are now solely focused on immune-mediated diseases. With budoprutug, a potentially best-in-class anti-CD19 antibody, as our cornerstone asset, we are well positioned to address the significant unmet needs for patients with immune-mediated diseases. Budoprutug is truly a pipeline in a molecule. We are initially developing it for SLE, ITP, and MN, but it has the potential to expand into multiple other immune-mediated indications that are highlighted on an earlier slide. From a balance sheet perspective, we are well funded through 2027, enabling initiation of multiple phase 2 programs, the subcutaneous formulation clinical trial, and also execute on potential BD deals, allowing us to deliver on key value inflection milestones in this period. Finally, I'm sure you got a taste of our world-class team that has already achieved so much. This team has a track record of execution and delivering operational results, and we are excited to have come together at Climb to deliver inspired medicines to patients. With that, we will open up to Q&A.
Thanks, Brett. This concludes our formal remarks, and we would now like to begin the Q&A session. To ask a question, you will need to click the tab titled Ask a Question on the upper right-hand portion of your screen. We will do our best to get to all your questions. If we do not get to your question, we are happy to follow up after the event. With that, let's begin Q&A. For the first question, the data from PMN and the single case study and the additional renal indication looks promising. How should we be thinking about next steps for this program?
Yeah, Chris. So I think everyone heard from Dr. Cortazar earlier today, and we certainly share his enthusiasm about the potential of CD19 in renal diseases, particularly PMN, where we have some really exciting early data from a small number of patients. And I think what's particularly compelling about the data set is that, you know, all of the biomarkers and the clinical endpoints moved in the same direction, and that we're seeing some long-term disease remission and some complete responses in patients after just 2 cycles of our Budo being administered, which I think is just really encouraging in a disease where, you know, most other therapeutics that have been trialed in this indication have not produced the same rate of complete responses at 12 months that we're seeing in this study. So we're definitely very encouraged by the data and moving aggressively to bring that program into late phase development. Obviously, that will involve a number of steps, including making sure that we're lined up on the manufacturing, the non-clinical and the clinical side, working with regulators globally to align on what that late phase development program would look like. And so all of that work is going on right now within the company, and we're looking forward to keeping everyone updated as we make progress on all of those fronts. Maybe I'll turn it over to Jan to add some additional color specifically on the clinical side and how we've been thinking about the data and next steps as it pertains to the clinical development plan, and maybe some additional color from her perspective on the data that we've gathered so far in the PMN program. Jan?
Even though there's a very small number, thank you, Aoife, even though there's a very small number of patients who have been seen, who have seen our drug, the clarity that we are able to very, very rapidly reduce production of autoantibodies, that the fact of reducing them very quickly leads to a subsequent reduction in proteinuria in all of the patients, and the suggestion that there is a dose relatedness to that, the further suggestion that retreatment can get us further toward a complete response, all of which, even though they're just individual patients, are very, very promising. Enough so that taken together with the other things that we know about both our drug safety at much higher doses than we've used and what we know about using other B-cell strategies in PMN, I think that puts us in a place where we can now go into a well-designed and randomized control trial at the phase 2b level to look at doses that we already know can achieve responses and see what we can do with that over time. As Nishi has pointed out, we're very interested in the idea of treat to target, both in terms of giving a sufficient induction regimen to get everybody into a complete response, if that's possible, but also in terms of looking at maintenance. How many of our patients may be like Frank Cortazar's and achieve very long, durable responses, and how many might need additional therapy moving along. So including those elements in our phase 2b program is our challenge and also our opportunity as we move forward quickly in that disease.
Our next question, we've got a two-part question. How does the recent readout from the Amgen MINT study impact your strategy? And how does budoprutug compare to Uplizna?
Wow, yeah. So a very topical one, Chris, of course, I guess to be expected given the day that's in it. I think the short answer to the first part of that question is it really doesn't impact our strategy. We weren't surprised at all to see the positive readout from MINT, given what we knew about the biology of CD19, given the strong data that had been put up in the NMOSD indication. We fully expected that we would see Uplizna efficacy in the myasthenia gravis indication. So we were very pleased and gratified to obviously see the card turn over as we expected. But based on our understanding of the biology, that wasn't surprising. So in the short term, it doesn't really impact our strategy. Our plans remain unchanged. We're lucky enough that Nishi is actually calling in from the AANEM conference, and thank you to her for taking time away from the conference to be with us today. So maybe for the first part of the question, I'll hand over to Nishi to provide some additional color, on our interpretation around the data that was shared just this morning. And then for the, how we kind of think and compare ourselves to that asset, maybe I'll turn over to Stephen for some additional color on the science side of things. So Nishi, why don't you give us your perspective on the data? You're on the ground there at the AANEM conference, and maybe you can provide your perspective on the MINT data that was just shared today.
Thanks, Aoife. As you said, I'm here at the meeting, and I think inebilizumab has performed well across 3 indication study and has a favorable risk-benefit profile. So in many ways, it's shown the tremendous opportunity we have for budoprutug across a range of diseases. We plan to develop budoprutug, as we discussed, not only to demonstrate efficacy and address unmet need, but we'll push further with a treat-to-target approach. As discussed, our anticipated study designs are patient-centric, where dosing can match individual needs. And potentially, this could drive further efficacy and a tailored treatment approach. We know B-cell repletion occurs at various times in each patient, and looking at each patient, their disease, and treatment parameters, we believe in our development plans of the potential of budoprutug. Stephen, did you want to add anything?
Yeah, in terms of thinking about, Uplizna or inebilizumab relative to budoprutug from a preclinical standpoint, both are IgG1 antibodies that bind CD19. Both are very potent in terms of their effector function, in terms of imparting ADCC. The FC region on inebilizumab is fully afucosylated. Ours is low fucosylated. Again, both enhance binding to FC gamma receptors. So, we're impressed by the PD of Uplizna, and think our molecule is just as potent. And if you look at the B-cell depletion data from the MN study, doses as low as 100 milligrams are getting subjects to complete depletion. So we think we have a really potent antibody on our hands, and in terms of mechanism, it behaves a lot like Uplizna.
Great, thanks, Stephen.
Okay, our next question, it's a long one. For IgG4-mediated diseases such as MN, would a CD19 targeting approach using an antibody be viewed as chronic treatment, or would it be viewed as a set dosing regimen that would lead to a remission until the B-cell compartment re-expands, or a functional cure due to complete depletion of B cells and the immunoglobulin repertoire, which should include the autoantibody driving kidney damage?
Yeah, so I think that's a really pointed and intriguing question. And I think we're starting to see hints of an answer to that question in the data that we've seen from the PMN study that Frank shared earlier today. As most people know, that membranous nephropathy is an IgG4-mediated disease. And in the data set that we shared earlier today, we can see that, despite the fact that patients just received 2 rounds of administration of Budo, we were getting these long-term disease remission, even after you would expect that the B cells had returned to baseline. So we're starting to see hints of that in the data set that we've seen so far. And I think that's really kind of led into some of, the comments Jan made just a short while ago around how we're thinking about further development. It's certainly possible that there will be a subset of patients where we can induce long-term disease remission following, 1 or 2 courses of treatment. And I think that could be really transformational in some of these immune-mediated diseases, that we can induce long-term disease remission following a short course of treatment, such that patients do not need to take long-term immunosuppressive treatment. I think that would be a pretty special thing to be able to achieve as a drug developer and as a physician. I think it would be a pretty amazing thing to do. And we'd love to be able to offer that to lots of different disease groups if we can. Jan, do you want to add color in terms of where we think we might be able to achieve that outside of IgG4 mediated diseases, or other ideas you have along those lines?
I think what's important in a lot of the disorders that we're going at is that there are autoantibodies that are identifiable and measurable, and they are a way of knowing the extent to which we've reduced production of the autoantibodies. And since we believe that there may be a separation between the overall recovery of antibody-generating B cells and the recovery of autoantibody-generating B cells, it's important to have that early warning sign. We think we have it in the IgG4-mediated diseases, and there are a number of diseases that are mediated by IgG1 and 3 where we also have it. And with our ITP study, we're moving forward in that direction. At the same time, we are developing a sub-Q formulation. So if there are individuals and disorders in which chronic administration is the best approach for that patient or that disorder, we're in a good position to enable people to be able to do that readily.
Great. We have another question on MINT. Can you elaborate on the Uplizna data in MINT, especially regarding the onset and durability of effect?
Yeah, so I think that one is probably best handled by Nishi. Nishi, is that one that you can provide some perspective on?
Yeah, thank you, Aoife. Seeing the MINT data today, I think there's 2 parts really to the question. One is about the timing of efficacy and then the durability of treatment effects. So I'll take the timing part first. And I think seeing the statistical significance, first separation, then significance at week 18 is not entirely surprising, given that the MINT study is really a high bar study design. Remember, patients could enter the MINT study on steroids up to 40 milligrams, so no small dose. The patients were then forced tapered. So the MINT study does something hard, namely it tries to prove efficacy while taking away steroids. It seems plausible and maybe even likely to me that if you force taper patients off steroids, many will decline. But Uplizna overcame that and, demonstrated efficacy, essentially jumping a higher bar. The MINT study was designed to treat essentially a real patient in a real situation. So judging it by speed of onset, I think, doesn't consider the actual trial strengths and the patients they aim to treat. So I think, again, it's not entirely surprising, and I continue to feel that the data set is strong. The durability of treatment effect, what was shown today was week 26 data for the pooled analysis and the 2 antibody subtypes. The AChR arm is controlled to week 52. So Amgen will have the opportunity to not only show week 26 data, but to my knowledge, the longest RCP duration of any MG study out to week 52. I would anticipate, based on Uplizna's performance in other indications like NMOSD, we'll continue to see durable treatment effect out to 52 weeks and then with the open label extension period. So I think it's a tough question, but I feel I've addressed it as best as I can today.
Great. Thanks so much, Nishi. I mean, it's difficult. The data's just come out. You know, we're all going to be poring over it, I think, over the next couple weeks and months to continue to glean as much as we can and as many learnings as we can from it. So thanks so much for being prepared to be on the spot there. Next question, Chris.
Yes. Can you talk about safety, particularly the impact of long-term B-cell depletion on immunity and response to vaccines like seasonal vaccines?
Yeah, and I think that's where, you know, there was more data, I think, coming out, again, probably getting back to this morning and some of the data that came out from the myasthenia gravis readout. Certainly, I was very encouraged by the safety. Now, this is the third placebo-controlled study, right, Nishi, of CD19 targeted antibody with, I think, a very consistent and favorable safety profile. And we now have long-term safety data from the NMOSD indication that has been marketed for a number of years, I think, and no surprises. You know, very consistent safety profile has been maintained through the post-marketing experience. You know, Nishi, you're probably closest to this than anyone. You know, any additional comments you want to make specifically around the infection risk that I think is probably driving this question?
Yeah, well, I think you touched upon already the 3 successful studies for a CD19 naked monoclonal antibody, and you talked about the post-market experience. I think it's safe to say we know the most data is available today around the NMOSD indication. And in the trial setting, it performed well. And from an infection point of view and immunoglobulins, they were typically only mild or modestly impacted. And when you look at study serious infections or AEs, it was not predicted by whether patients' immunoglobulin levels were near normal or were in fact very low. So I think that, coupled with the long-term safety data that's been shared out to 3 and 4 years, show no increased infection risk. And just kind of drilling down on the disease of NMOSD, I think it's worth thinking about the fact that this disease itself is where treatments persist. They're not withdrawn because the risks to patients are too great. So we're getting the opportunity to see how long-term chronic Uplizna performs. And to date, the risk-benefit profile continues to look encouraging. And as you mentioned, the Mitigate trial results, the MINT trial results have come out and seem to be a recapitulation of the NMOSD data set. I think the other point to mention from the data that will come forward from MINT and Mitigate is that both of those studies were conducted during the CD19 pandemic. And that adds more to the picture, as the pandemic essentially could be considered an unmasking event for infections. And then to the last point, I think to round out the discussion, the vaccination picture and childhood vaccines and their titers have remained well preserved with Uplizna, and we'll continue to learn around contemporary vaccines with the MINT and Mitigate data sets. Thanks, Aoife.
Great. Thanks so much, Nishi.
Next question is regarding the ITP program. Can you talk about any learnings from the recent argenx pivotal program results for Vyvgart and how you're incorporating these learnings into your clinical trial design plans?
Yes, this is Jan. It's a good question. It's also a very long-term question. We believe that our agent can be much more effective than the FcRn blockers in this disease state for a number of reasons. First, because since there is no impact on production, while those agents are very safe, there's a limit in how far down they can drive an antibody. And so, and it's limited by the rate of destruction of antibodies in the RE system. Whereas with a agent that's targeting production, we can drive it down as far as can be tolerated from a safety point of view, which, as Nishi and Eva have pointed out, is really quite impressively low. But something that we learned from their program, and it's an important thing, and I think we've learned that throughout the AI programs, is that control of the background therapy is essential when you are dealing with diseases that are going to be on background, if you're going to be able to see a delta. It is also at these diseases, and it's certainly true of ITP, there is huge heterogeneity in the patient population, the nature of the diseases, and the responsiveness to therapy. You saw that the response rates were really quite low on both sides of that phase 3 program. And when there is that kind of heterogeneity, sufficient size and also sufficient control over the factors and stratification for the factors that that drive the response becomes quite essential. You can be lucky or unlucky if you don't have control of those. So we see the initial studies that we're doing in ITP as being oriented toward understanding what the maximum effect we can get is, what the drivers are, including genetic and measurables of response are, and before we start designing our randomized control trials. So thank you for the question. It's really an important question in all of AI.
Next question, can you get deep B cell depletion, and how do you know you get into the tissues?
Yeah, I think that's a great question for Stephen. Stephen, do you want to address this question?
Another great question. Thanks for the question. It's an important one. And maybe I'll start by just reiterating a couple key points from the presentation. So, right, we have prior clinical data with the anti-CD20s like rituximab that provide evidence that tissue level B cell depletion is happening with monoclonal antibodies. The CD20 positive B cells are gone, though in some instances we can see that CD19 positive, presumably CD20 negative B cells remain. And this is really a distinction of target antigen. And then we have our internally generated data from a preclinical model where we created and treated these human CD19 transgenic mice with budoprutug, and we showed tissue level B cell depletion. And we believe these data are translatable to humans. We looked at spleen, we looked at lymph node, and even bone marrow in that model, and saw greater than 90% reductions in B cells at 7 days post-dose. So aside from those data, the clinical data with anti-CD19 monoclonal antibodies are showing clinical responses that would lead one to believe that tissue level depletion is occurring. For instance, again, in our MN data set, we've seen subjects maintain clinical response even when B cells are repopulating, supporting this concept and the potential for, in quotes, immune reset in certain diseases. But going forward, we plan to continue to interrogate B cell pharmacodynamics by attempting to access tissue samples when and where we can, and potentially include additional immunophenotyping to better understand the types of B cells in circulation pre and post treatment. So overall, we have strong conviction about the potential of budoprutug specifically to access and achieve tissue level B cell depletion. And we really do appreciate the question, as it's super important when considering the clinical implications. So thanks for the question. But yeah, we believe that Budo will achieve and access tissue level B cell depletion.
Thanks. I think we have time for a couple more questions. This one is, why would CD19 be better than CD20 in antibody-mediated diseases?
Yeah, I think that's sounds like another one for you, Stephen. Do you want to provide a perspective on that? And then we can maybe hand it over to Jan to provide some clinical color.
Yeah, for sure. Again, from a more basic scientific level, we showed the slide previously that goes over sort of the expression profile of these various antigens. And again, a key differentiator for CD20 versus CD19 is that the CD20 expression tends to wane on those autoantibody secreting cells, namely the plasmablasts and short-lived plasma cells, right? So CD19 expression is retained on those cells, and we think it's really important to be able to directly target and deplete what we believe are the pathogenic cell types. So as we've shown in our MN data set, we think this phenomenon could lead to more rapid, more meaningful responses in patients. And again, it's largely due to this expression profile on your key pathogenic B cell subtype. But Jan, please feel free to add.
No, I think that is really the crux of it. We have seen failures with anti-CD20, and we have seen instances in which CD19 targeted therapies can rescue those failures. The very, very rapid reduction in the levels of circulating pathogenic autoantibodies relates to that ability to remove the plasmablasts. And I think that's key to the difference.
Great.
Our last question, how do you view additional opportunities for business development or additional indications for budoprutug?
Yeah, so that's a great question. Bill, maybe you want to handle the BD question, and I can take the second part of it around potential expansion for budo.
Yeah, thanks, Aoife. So we view Climb Bio, of course, as a leading I&I company, and our foundational asset at Climb, of course, is budoprutug, the anti-CD19 antibody. So I guess with that in mind, we have a two-prong approach to BD. The first is to expand the indications that were with budoprutug, and of course, Aoife, you can talk about that. But evidence is now mounting that targeting CD19 expressing B cells is an effective approach in all autoantibody-driven diseases. And so we're looking for indications, of course, where there's a clear unmet need and commercial opportunity. And remember, we mentioned we do have an SC product that we're moving forward to make this drug accessible for any indication, even those with large patient populations. The second prong is being opportunistic in evaluating the additional BD efforts that can support budoprutug in autoantibody-driven diseases or to expand into other autoimmune diseases. That being said, we have strong conviction in budoprutug that it can be a cornerstone treatment for these autoantibody-driven diseases. So we have a very high bar for new assets, but we are evaluating these opportunities. Aoife, any thoughts you want to share here?
No, I think you just answered both parts of the question, Bill, with your two-pronged approach. Yeah, I couldn't agree more. I think, we feel budo is a really great asset. I think the conviction and the data set that underlies and kind of gives support to that continues to grow. And, the data that was just shared this morning is kind of, I think, another piece of that. So being able to unlock the value and making sure that we can bring that forward in as many indications as makes sense clinically and commercially, I think has to be number one priority. And that's what we're going to be focused on in the short term, while obviously keeping an eye out for other things that could be opportunistic in the background too. I think you put it very well. Maybe we've time for one more question, Chris. As I think we have a few more minutes, we can take one more if there is one.
Sure. Similar to the last, it's how do you think about further opportunities for budoprutug, and where do you plan to develop?
Yeah, so I think, we have our three-pillar, our three opportunity set strategy. I think Brett showed a very nice slide that outlines the diseases within kind of each opportunity set. We have one disease and one indication in each of those three indication sets that we're pursuing right now. There's lots of unmet need in the I&I space. There's many diseases in the antibody-mediated buckets that remain untreated or undertreated. And we're certainly interested in exploring. We have ongoing work evaluating, what diseases might be interesting to pursue, and we look forward to sharing some of that work with the investment community as we choose what areas we might like to move into. So look forward to providing additional color on some indications that might look interesting as we finalize some of those decisions. Great. Well, I think that wraps things up. So thank you so much, everybody, for joining us today on the call. Thanks so much to the support team for helping pull this together. Look forward to keeping everybody updated as we execute on the exciting program that we've outlined today. And enjoy the rest of your day. Thanks, everyone.